anesthesia just from doing an ORIF, that is open reduction and internal fixation, on a patient who had distal femur fracture, a young patient, and the fracture was through the growth plate. It seems like the boy is still growing and he will be a very tall person. We used spinal anesthesia for his surgery, and this is a form of regional anesthesia which is applied to the lower part of the body, whereby you'll take away the sensation or feelings of pain away from the body at the level of the umbilicus downwards. So the anesthetist introduces regional anesthesia into the subarachnoid space where the nerves are running down to anesthetize the lower parts of the body. Now, this anesthesia is indicated for surgeries of the lower limbs, like in the foot, in the ankle, the tibia, the knee, the femur, the perineum, or even the pelvis. In cases of obstetric surgeries like cesarean section, also in gynecology, maybe oophorectomy, removal of the uterus, that is hysterectomy, all those can be done with this form of anesthesia. The technique of doing this usually is one, preparing the patient well from the ward, where you have to give IV fluids, at least 2 liters. Then you make sure the HB is within normal, and then the patient doesn't have anything else which precludes surgery. When these patients come in, they need also to have a brannular or cannula, that is an IV access to their bodies for administration of drugs and IV fluids, and just in case you need blood, you can use the same route. So once the patient is been received to theatre and it's been put on the table, the anesthetist will clean the back side of the patient from around T12 to S1 levels, cleaning to the sides around the cotratus lumborium areas, so that to reduce the risk of infection when introducing the drug. Then application of antiseptic to the area of injection. You apply and wait for some time to allow for effect to take, and then wipe a little if you have put excess. Then apply local anesthesia, about 2 to 3 ml into the skin and the other tissues as you go in. By the way, some of the tissues that we go through include the skin, subcutaneous tissue or fat. Then you go through the interspinous ligaments, then supraspinous ligament, interspinous ligaments, then ligamentum flavum. From the ligamentum flavum, you go to epidural space, then the dural mater, and then finally into the subarachnoid space. So these are the areas you infiltrate as you go in. Now this is before the actual administration of the drug. The local anesthetics may be bupivacaine or any other. So the way you determine the area of injection is that you go both sides, you determine the highest points of the ilium, and then you draw a straight line. So in the midline, that area, that is where it is, and the line that you draw it is called a Toffler's line. So the injection can be done while the patient is seated, especially for pregnant mothers of these patients. and those who may have spinal abnormalities like scoliosis. So for lean people and anyone without the indications we just mentioned, you can do lateral position where they flex themselves on the edge of the table, operating table. The legs of the knees are drawn up to the chest, and the shoulders and the neck and head are also flexed down towards the knees. So that way it opens up the area of injection. So the technique is whereby the anesthetist or the one who's applying this medication, you take the spinal needle and you direct the beaver, less than 50 degrees towards the area of injection and the umbilicus. So you try to go in. So there's a bit of resistance until when you feel it's giving way. At that point it has gone past the ligamentum flavum. And then you draw the stylet for you to see whether there is a CSF flowing, and it should be clear. If you see any blood, then it means you are in a vessel, and probably you might, the Barton's plexus, you might end up injecting into the wrong place, so you get out and to dry again. Once you have gotten in, now you will draw the CSF to see that it's in the right place, and if it is blood, like I said, we just change the position and they clean up the spinal needle. But if you are in the right place, then you get the bupivacaine or the local anesthesia, the regional anesthesia that you are applying. Attach the needle, the syringe to the needle, try to pull that back for you to see whether you are still drawing CSF, and that means it is still in the right place, and then inject slowly into the canal. Once you are done, quickly pull out the spinal needle and make the patient lie on the operating table quickly. Some of the indications, in areas whereby you can use the drugs, we have already mentioned them, but this type of anesthesia is preferred for cases like patients who may have heart disease, who may have kidney failure or liver problems. All this, when you go in, it becomes easy for you to use this type of anesthesia than using general anesthesia. So the contraindications of this type of anesthesia include patient refusal. There are those patients who refuse to have this type of anesthesia for some reason. For example, if you are operating on a patient with machines and they are making noise, patients will be hearing them, because with this type of anesthesia, usually they are awake and some of them may be scared. So if the patient refuses this, don't force it. If the patient is hypovolemic, or the patient has shock, has septicemia, has coagulopathies or bleeding disorders, is paralyzed, the patient has some neuropathy, like demyelinating disease or polio, or if patients have fractures to the lumbar vertebra, where you're going to inject, or even high up. So in those patients, you should avoid spinal anesthesia. Some of the complications that may arise from this type of anesthesia include post anesthesia headache. It may be mild, some patients report moderate headache, but some may have severe headache. And this is because of the puncture of the dura, and there is continued or occasional leakage of the CSF from the canal, and therefore leading to headache. Its management is conservative, where you ask the patient to take bed rest, to rehydrate. You can give caffeine, you can give analgesics, sometimes you give opioids, so with time it heals. And some have even said use of abdominopelvic binders. Yeah, they usually help. You can also get hypovolemia in some patients because of what we call a sympathetic blockade. The regional anesthesia will block the normal physiology of the sympathetic nervous system and leads to dilatation and of vessels, therefore leading to hypovolemia. Somehow, as a blessing in this case, this type of anesthesia can help in reducing the blood pressure of a patient who already had hypertension before he or she came for surgery. So it usually reduces the blood pressure, so it can be a blessing in disguise. Other complications that may come in are like hematoma formation. When you are injecting into the canal, you hit a vessel, maybe Bartison's plexus, and it leads to hematoma formation, which may also have pressure effects on the nerves or the cord itself. You may also introduce infection into the canal, leading to meningitis or encephalitis. If you don't clean well the area and wait for a few minutes, like we said, before you inject, your spinal needle may carry infection along with it into the canal. Sometimes you may have reactions, local reactions, and sometimes you may inadvertently inject into the blood vessel, especially with the infiltration of local anesthesia. And if it gets into the vessel, it will cause ventricular trigeminy or even cardiac arrest and death in the patient. That's why when you are applying it, you need to suck. When you suck, you try to see whether you are in a vessel. So if you see blood, you move from there. If you don't, then that's when you can inject. You need to remember the anatomy very well, like we mentioned, the layers you go through, but also the type of patient you are dealing with. In children, the cord terminates at L3, whereas in adults it terminates at around L1. So remember those differences, anatomical differences in your patients. So spinal anesthesia is a good one. It can be employed whenever you need it for those indications that we give. So you should learn about it and know how it is done. And for those who are interested in specializing in anesthesia, it's an interesting area. Some have even specialized in regional anesthesia, and spinal anesthesia is one of the regional anesthesia. So, thank you very much, and I think that's all for the day. So, bye.